Welcome to the deep dive. Today, we're really getting into something quite profound, aren't we? The world of surgery.
We are. Specifically, the ethical and legal tightrope that surgeons walk every single day.
Yeah, it's this incredibly high-stakes environment. We're going to be looking at the rules, the frameworks that govern everything a surgeon does before, during, and after an operation. We've got some core surgical texts here, Bailey and Love, for instance, guiding us.
And our aim really is to break down how surgeons handle this immense power they have while making sure they keep that vital patient trust.
It's essential stuff because it touches on this kind of social contract, doesn't it, between the patient and the surgeon?
Absolutely. We're looking at the bedrock principles. Consent, capacity, confidentiality, professional standards, these are what regulate this unique power dynamic.
And when you actually stop and think about it, it's kind of staggering. We call it the surgical paradox. If I, just an ordinary person, deliberately cut someone, make them bleed, cause pain, leave scars, well, I'd be looking at serious criminal charges. Assault, maybe worse.
Manslaughter, grievous bodily harm, potentially even murder, depending on the outcome.
Exactly. Yet a surgeon does actions that look very similar every day. And they're trusted. They avoid criminal charges. How?
And that's the crux of it. It all hangs on one absolutely critical legal concept. Intention.
Intention.
Yes, the surgeon's intention is strictly limited. It's about treating illness, injury, or disease. That's it.
So the harm, the cutting, the bleeding.
That's seen either as necessary to achieve the treatment goal, or it's an unavoidable and intentional side effect. The law accepts the intent is therapeutic, not harmful.
Right. Therapeutic intent. That's the key that unlocks the surgeon's power. So our mission today is to map out the boundaries using these expert sources that keep that power in check.
Because these principles, autonomy, consent, confidentiality, they're not just paperwork, are they?
No, not at all.
They are the absolute bedrock safeguards. They're what make cutting into someone a legitimate therapeutic act instead of a crime. Surgeons get extraordinary leeway, but only if they stick rigidly within these moral and legal lines.
Okay, so let's start with the absolute cornerstone, you could say, of modern medical ethics: respect for autonomy.
Yes, when we talk about a surgeon's duty of care, people often think first about, well, saving lives, fixing physical problems.
Keeping the patient alive and healthy.
Right. But the sources are really clear. The duty goes much deeper than that.
How so?
It has to start with respecting the patient's autonomy, their fundamental right to make choices about their own body and their own treatment.
Why is that so central?
Because the patient is the only one who can weigh the outcomes, the risks, the benefits against their own life, their plans, their values, their beliefs. It's intensely personal. That the surgeon overrides that, the whole trust relationship just crumbles.
And the ultimate expression of this autonomy, maybe the hardest one for clinicians, is the patient's right to say no.
Absolutely. The right to refuse treatment.
Even if the surgeon thinks that refusal is, well, medically wrong, illogical.
That's the legal reality. The consensus, morally and legally, is pretty solid. A patient with capacity can refuse treatment, even life-saving treatment.
Wow, that must be tough in practice.
It is, but the law backs it up.
Huh.
There was a key case, for example, involving a woman who had capacity. She understood everything, but refused renal replacement therapy, dialysis, essentially.
And the doctors knew it would likely save her life.
Yes, but the court stepped in and made a really crucial point. That making a decision that seems unwise or illogical or even unreasonable to others doesn't automatically mean the person lacks capacity.
Ah, okay. So as long as they understand the situation and the consequences.
Their choice has to be respected. Even if the clinical team completely disagrees, the patient is sovereign over their own body. That's the principle.
And this right to refuse isn't just for the here and now, is it? People can plan ahead.
Correct. Through things like advanced decisions, sometimes called living wills, or by appointing someone with lasting power of attorney for health decisions.
So you can state now, while you have capacity, that you wouldn't want certain life-saving treatments in the future.
And that decision has legal force later on, even if you've lost capacity by then. It locks in your autonomous choice.
Okay, so if autonomy is the guiding star, then getting informed consent is how we actually navigate by it in the clinic.
Exactly. It translates the principle into practice. And that means disclosure, proper disclosure.
It has to be thorough, doesn't it? Because the gap in understanding between a surgeon and a patient can be huge.
Massive. We live in a world of jargon, probabilities, risks that just aren't intuitive to most people. You can't expect a patient to just guess what might go wrong.
The sources give some really stark examples of these non-intuitive risks, like the idea that operating on one eye could very rarely affect the sight in the other eye.
Who would think of that? No layperson would assume that connection. It has to be explained.
Or the example of the budding Olympic gymnast.
Ah, yes, that's a classic illustration. She has a lump, seems harmless in the side of her neck, posterior triangle.
Okay.
Surgery seems straightforward. But there's a nerve there, the accessory nerve. If that gets damaged during the operation,
What happened?
it affects shoulder function. Maybe subtly, maybe significantly. For most people, an inconvenience. For an aspiring Olympic gymnast.
Career over. Devastating.
Precisely. The surgeon can't possibly know her dreams, her life plan, so they must tell her about that specific, perhaps rare risk. Then she weighs it up against her goals. The decision becomes hers, not just a clinical one.
So, to make sure that decision is genuinely informed, there's a kind of checklist, isn't there? Essential things that must be covered in that consent discussion.
Yes, the sources lay out 6 key points. These are non-negotiable for valid consent.
Okay, let's run through them. 1.
First, the condition itself. What's wrong, and why is surgery actually needed now rather than, say, medication or just waiting?
Makes sense. 2.
Second, the type of surgery being proposed. What exactly will be done, mechanically speaking, and how is that supposed to fix the problem?
Clear. 3.
Third, the anticipated prognosis and the expected side effects. What's the likely outcome? What will recovery be like? What things will definitely happen? Restrictions, pain, scars.
Right. The inevitables. 4.
Fourth, the unexpected hazards, the complications, things you hope won't happen, but might. This includes the rare but serious stuff. The gymnast's nerve injury example fits here.
Got it. 5.
Fifth, alternative treatments. Are there other options besides this surgery that might work? Medication, different procedures, radiotherapy.
Yeah.
The patient needs the full menu.
Crucial. And finally, 6.
And sixth, the consequences of doing nothing. What happens if the patient chooses no treatment at all? What's the natural course of the condition? This gives them the baseline to compare against.
6 points. That's a comprehensive discussion. It really frames it as a shared decision, not just the surgeon telling the patient what's going to happen.
That's exactly the goal.
Yep.
So those 6 points cover the what of disclosure. But good practice also dictates the how and where. The environment matters.
Right. You can't just grab someone in a busy corridor 5 minutes before they go to theater.
Absolutely not. Rush discussions, distractions. That's not conducive to understanding. Good practice demands a quiet place. Time for the patient to think, ask questions, voice worries.
And using aids helps too, presumably. Written info, diagrams.
Definitely. And crucially, in the patient's preferred language. It needs to be accessible. Anything to bridge that understanding gap we talked about.
And you mentioned something critical earlier. Who should be having this conversation?
Yes.
Hmm.
Ideally, for any significant procedure, it must be the surgeon who will actually perform the operation.
Not a more junior member of the team.
Not unless it's a very minor procedure, they are competent in performing themselves. For major surgery, delegating consent to someone who hasn't done the operation, who doesn't intimately know the risks and alternatives, well, that's just not good enough. The person taking responsibility for the surgery should be the one ensuring the patient understands what they're consenting to.
It's about accountability.
Entirely.
And it's not just about delivering the information, is it? It's about making sure it lands. Checking they've actually understood.
Yes. We have to avoid just going through the motions, ticking boxes.
So how do you do that? How do you know they've understood?
Well, first, ditch the jargon. Speak plainly. Use interpreters if there's a language barrier. But the gold standard. Ask the patient to explain it back to you.
Ah, the teach-back method.
Exactly. Can you tell me in your own words what we're planning to do and what the main risks are? If they can do that reasonably well, you have much more confidence they've actually grasped it. It turns consent from just a legal hurdle into a real ethical dialogue.
Okay, so what happens if a surgeon fails in this duty? They don't disclose properly. Assuming their intent was still therapeutic, what legal trouble are they in? You mentioned 2 civil actions.
That's right. 2 main avenues for the patient, legally speaking. The first is battery.
Which sounds serious, like criminal assault.
It's the civil equivalent. It basically means touching someone without their permission. For surgery, to avoid battery, the surgeon needs to have told the patient in broad terms what procedure they intend to do and on what part of the body.
So we're going to remove your appendix, that kind of level.
Pretty much. If the patient agrees to that general idea, then the actual touching isn't battery. Battery is about the act of unconsented touching itself.
Okay. And the second, legal action. This is where most cases happen, right?
Yes, this is negligence, specifically the tort of negligence.
And how is that different from battery?
Negligence isn't about the touching itself, it's about the information.
Hmm.
The patient might have agreed to the operation in broad terms, so no battery. But if the surgeon failed to warn them about the material risks involved, and one of those risks happens and causes harm.
Then the surgeon breached their professional duty of care through inadequate disclosure.
Precisely. Negligence is about failing to provide enough information for the patient to make a truly informed choice about the risks they were accepting.
And this is where that landmark UK court case comes in, isn't it? Montgomery?
Montgomery v. Lanarkshire Health Board, yes, 2015. It completely changed the landscape of consent in the UK.
How so? What was the standard before Montgomery?
Before Montgomery, the standard was generally the Bolam test. Basically, did the surgeon act like a responsible group of other doctors would have acted?
So what would other doctors have told the patient?
Essentially, yes. It was quite paternalistic. Doctor knows best about what risks are worth mentioning.
And Montgomery changed that.
Swept it away. The Supreme Court said the test is no longer what doctors think the patient needs to know. The test is now. What risks would a reasonable person in this particular patient's position think are significant?
Ah, so it's patient-centered. What matters to this patient?
Exactly. It forces the doctor to think about the individual patient's circumstances, their fears, their values, what risks are material to them.
Like the gymnast example, the risk of shoulder weakness might be statistically small, but for her, it was highly material.
Precisely. So under Montgomery, that risk absolutely had to be discussed. It requires a proper dialogue, finding out what matters to the patient, not just reciting a standard list.
Which brings us to the consent form itself. That piece of paper everyone signs. You argue quite strongly it's often treated as, well, a myth.
It is, if people think the signature proves valid consent was given. It absolutely does not.
Why not?
Because the form only shows that some kind of discussion might have happened. It doesn't prove the patient understood it, or that all the relevant risks were covered, or that they weren't pressured. We see it all the time. Patients sign under stress, maybe without reading it properly, maybe the discussion was rushed.
And later, if something goes wrong, they say, I was never told about that risk.
Exactly. And the signed form alone is often very weak evidence against that claim.
So if the form isn't proof, what should surgeons be doing to protect themselves and properly document consent?
Good practice and legally safer practice is to make clear notes, contemporaneous notes in the patient's record.
What kind of notes?
Briefly outlining the key points, discuss the diagnosis, the proposed surgery, the main benefits, the specific significant risks mentioned, especially any the patient seemed worried about, alternatives discussed, and confirmation the patient seemed to understand and agreed to proceed. Maybe even reference any leaflets given.
So documenting the dialogue, not just the signature.
Yes, that provides much better evidence that a proper consent process occurred. Some people argue we should move towards documenting the dialogue itself, maybe even electronically, and eventually ditch the signature-focused form altogether.
Interesting. A shift in focus from paper to process.
That's the direction things should be heading.
Okay, so we've covered disclosure before surgery, that's consent. Now let's shift to disclosure after things have happened. Specifically, when something goes wrong. This is the duty of candor.
Yes, a separate but related duty. It kicks in after an intervention if an event caused harm, or even just had the potential to cause harm or distress. It's about being open and honest when things don't go as planned.
So, even if a risk was listed on the consent form, let's say damage to the ureter during a hysterectomy was mentioned as a rare possibility. If it does happen, candor still applies.
Absolutely. Just because it was foreseeable doesn't mean you don't have to tell the patient it actually occurred in their specific case.
Why? They were warned it might happen.
Because it did happen. It's a significant event in their care. They need to know for their ongoing treatment, understanding their recovery, potential future issues. The consent form warns of possibilities. Candor deals with realities that have occurred. It's about transparency regarding the actual events of their surgery.
Okay, that makes sense. But what exactly triggers this duty? You draw a really important distinction between complications of the surgery versus complications of the disease itself.
Yes, this is crucial for knowing when the formal duty applies. Let's take an example. A patient is waiting for major surgery, maybe for rectal cancer. While waiting, they develop a blood clot, a VTE. That VTE is serious, but it's generally considered a complication of the cancer, which makes the blood stickier. It's part of the natural history of the disease in some patients.
So no formal duty of candor triggered there.
Not in the strict sense relating to the care provided. It's a complication of the illness. Of course, you tell the patient and treat it, but it wasn't caused by something going wrong with their treatment yet.
Right. But change the scenario slightly. The patient has the cancer surgery, comes through fine. Then after the operation, they get a VTE because, say, the team forgot to continue their preventative blood thinners for the required length of time according to the hospital protocol.
Ah, now that's different. That VTE resulted from a failure in the care process, a deviation from the expected standard. Something went wrong with the management.
And that triggers the duty of candor.
Unequivocally, harm resulted from a lapse in care. You have a duty to be open about that.
And you emphasize that fault isn't the deciding factor for initial candor. Even if the team genuinely believes the complication happened despite perfect care, say an unpredictable allergic reaction, they still need to be candid.
Yes, the initial duty is about informing the patient about the event itself. Why? Because that information is vital for them.
How so?
Well, take the allergy example. Even if no one was at fault, the patient absolutely needs to know they had that reaction so they can avoid the trigger in the future. It affects their future healthcare decisions regardless of blame. Candor is about giving the patient the information they need about what happened to them.
But what about explaining the why? If it's not clear immediately whether there was a mistake, can that part wait?
Yes, that's an important nuance. You need to be candid promptly about the fact that something unexpected happened and harm occurred. I'm sorry to tell you that during the operation, X complication occurred. We're doing Y to manage it. But figuring out why it happened and whether suboptimal care played a role might take time. It might require a formal investigation. So candor about definitive cause and fault might need to be deferred until that investigation is complete. You don't want to speculate or give inaccurate information.
So immediate honesty about the event, potential delay on the definitive explanation of fault?
Exactly. Honesty about the what's straight away. Honesty about the why once the facts are clear.
Right. Let's quickly recap the essentials for valid adult consent. You need 3 things: sufficient information, disclosure, no coercion, and the patient must have capacity.
Correct. Capacity is the first hurdle.
And this gets tested dramatically in emergencies, doesn't it? When a patient arrives unconscious or confused.
That's where the doctrine of medical necessity comes in, the legal safety net.
How does it work?
In a genuine emergency, if a patient lacks capacity, a surgeon can operate without formal consent if it's necessary to save their life or prevent serious permanent harm, like stopping massive bleeding after trauma.
But there's a key condition.
The treatment must clearly be in the patient's best interests. It has to be an action any reasonable person would want in that situation.
But what if the patient, before losing capacity, made it clear they wouldn't want that specific treatment? Maybe they have an advanced decision refusing blood transfusion.
Well, a valid advanced decision trumps necessity. If there's a legally sound prior refusal, you have to respect it, even in an emergency.
So necessity isn't absolute.
No. And you also need to be prudent. If someone's incapacity is clearly temporary, maybe they're drunk or concussed, but likely to recover capacity soon, you shouldn't rush into non-essential surgery under necessity. You wait, if possible, until they can decide for themselves.
And the sources warn against using necessity just for convenience, right?
Absolutely. Necessity is only for emergency life or limb-saving treatment. You can't use it as an excuse to do more than necessary. If a patient consented to a minor diagnostic procedure like a DNC.
You can't just decide while they're under anesthetic to do a hysterectomy because you think it's a good idea medically.
Exactly. Even if you genuinely believe it's in their best interests, doing an operation they didn't consent to outside of a true life-saving emergency is battery and negligence.
Okay, let's talk about children and young people under 18s. The default is they lack capacity, especially under 16.
Under 16, they are presumed incompetent, legally speaking. But that presumption can be overturned if the child demonstrates Gillick competence.
Gillick competence. What does that mean in practice?
It means the child shows enough maturity, intelligence, and understanding to fully grasp what's involved in the decision, the procedure, the risks, the benefits, the alternatives. If they reach that level,
they can consent for themselves, even if they're, say, 14.
Yes. If deemed Gillick competent for that specific decision, their consent is legally valid. It recognizes their growing autonomy.
What about the parents, then? If the child is Gillick competent, do the parents lose their say?
Well, for children who aren't competent, parents, or those with parental responsibility, give consent. If the child is competent, Their consent is the legally effective one. However, good practice is always to involve parents and take the child's views seriously, whatever their age.
But there's a twist with refusal, isn't there? Can a Gillick competent child refuse treatment?
This is a complex area. While a Gillick competent child can consent to treatment, the courts have generally held that they cannot refuse necessary life-saving treatment if their parents or the court consent to it.
So they can agree, but they can't necessarily veto life-saving care.
Not until they're 18, essentially. The law prioritizes preserving the life of a minor, even a competent one, over their refusal in those critical situations.
Right. Now, adults 18 and over, capacity is presumed, isn't it?
Yes, the starting point is always assumed capacity. But that presumption can be challenged if there's a reasonable belief the person might be unable to make the decision.
And if capacity is questioned, we use the framework from the Mental Capacity Act 2005 in England and Wales, at least. There's a two-stage test.
Correct. It's sequential. You have to address both stages.
Stage 1.
Stage 1 is the functional test. Can the person actually make the decision? This involves checking 4 things. Can they understand the relevant information? Can they retain it long enough to make the decision? Can they use or weigh that information? And can they communicate their decision?
Understand, retain, weigh, communicate. If they fail on any of those,
they fail the functional test for that specific decision. Capacity is decision-specific and time-specific.
Oh, okay. And if they fail stage 1, what's stage 2?
Stage 2 is the diagnostic test. Is their inability to make the decision because of an impairment or disturbance in the functioning of their mind or brain?
So conditions like dementia, delirium, severe learning disability, brain injury.
Or sometimes severe mental illness. Yes.
Yeah.
There needs to be a link between the functional inability and an underlying condition. Both stages must be met to determine lack of capacity.
And it's interesting, the sources point out that just because someone is detained under mental health legislation, it doesn't automatically mean they lack capacity for surgical decisions.
Absolutely key point. Detention for psychiatric treatment is separate from capacity for other decisions. You still have to assess their capacity for the specific surgical consent. If they do lack capacity for that, then treatment proceeds under the best interests framework. But if they have capacity, their decision, consent or refusal, stands, even if they're detained.
So if an adult lacks capacity, decisions must be made in their best interests. That sounds broad. How do clinicians actually determine best interests?
It is broad, deliberately so. It's not just about medical best interests. The MCA requires considering the person's welfare in the widest sense: medical, social, emotional, psychological,
Spiritual.
Very. And crucially, it includes a strong subjective element. You must consider the person's past and present wishes, feelings, beliefs, and values. What would they likely have considered important?
You have to try and see it from their perspective.
Yes. The case law, like the Mrs. P case, involving a minimally conscious patient and a feeding tube decision.
Right, where the family felt she wouldn't have wanted it.
Exactly. The courts emphasized that decision makers have to make a real effort to understand the person. That means talking to family, friends, anyone who knew them well to get insights into their personality, their values, what they might have thought about this kind of situation.
Building a picture of the person, not just the patient.
Personally.
But there's a limit, isn't there? Even if the family is adamant about what the patient would have wanted, that doesn't automatically dictate the decision.
That's the ultimate legal position. The paramount consideration is always the patient's best interests. What they would have wanted is hugely important evidence for determining best interests, often the deciding factor. But it's not absolute. If, for example, their prior wishes seem completely at odds with their current situation and overall welfare, the clinical team, often with court backing, might have to justify overriding those wishes in order to act in their best interests.
It's a careful balancing act.
All
And one final point on this, the role of relatives. They provide crucial information, but they cannot legally sign a consent form for an incapacitated adult, can they?
No, absolutely not. Unless they've been formally appointed by the Court of Protection as a legal deputy for health decisions, which is very rare. Their input on best interests is vital, invaluable, but asking them to sign the consent form is legally meaningless and, frankly, unfair. It puts a burden on them they shouldn't have. The responsibility for the best interest decision rests with the clinician.
Okay, let's move into some of the most challenging areas now, life-sustaining treatment. Specifically, withdrawing things like feeding tubes, clinically assisted nutrition and hydration, or ACAH. There's been a significant legal shift here, hasn't there?
A huge shift. Historically, going back to cases like Bland in the 90s, The courts basically said that for decisions as momentous as stopping CNH for someone in a persistent vegetative state or similar condition, you had to get a court declaration first.
The courts needed to oversee it.
Yes, it was seen as a necessary safeguard. The courts acted as the ultimate protector of the patient's interests in these profound life and death decisions.
But that changed with the Mr. Y case in 2018.
It did. The Supreme Court looked at the situation again. Mr. Y was severely brain damaged, not technically PVS, but minimally conscious. His doctors and family all agreed withdrawing. The CNH was in his best interests, based on his previously expressed wishes.
And the court said?
They essentially said, look, decisions about withdrawing CNH happen frequently for patients with conditions like advanced dementia or stroke, and we don't require court approval every time if everyone agrees and the proper process is followed. Why should it be mandatory only for this small group of patients with prolonged disorders consciousness?
So they leveled the playing field.
In effect, yes, they handed back the responsibility, as some sources put it. The ruling established that you do not need to go to court to withdraw CNH if, and it's a big if.
Conditions apply.
Two main ones. First, you must rigorously follow all the procedures and guidance laid out in the Mental Capacity Act 2005. And second, there must be agreement between the clinical team and the patient's family or relevant others that withdrawal is genuinely in the patient's best interests.
So if the process is solid and everyone's on the same page, the clinical team can make the decision.
Yes. Which, as you can imagine, places enormous responsibility on clinicians to get the MCA process absolutely right.
The burden is squarely on them now.
It is. Any slip-up in following the MCA could make the decision unlawful.
And when is court involvement still required?
If there's any disagreement between doctors, nurses, family members, anyone closely involved, or if there's a conflict of interest, or if the decision feels very finely balanced and there's significant uncertainty about the best path, then you must apply to the court. The court remains the final arbiter in cases of dispute or doubt.
Okay. What about DNA CPR decisions do not attempt cardiopulmonary resuscitation?
The law here is pretty settled now. Doctors must discuss a DNA CPR decision with the patient if they have capacity. If they lack capacity, you must discuss it with their family or advocate.
Why is discussion mandatory?
Because the patient or their family might have information, beliefs, or perspectives the clinical team isn't aware of, which could be crucial to making the right decision for that individual.
Yeah.
Not discussing it is a breach of duty.
Is there any exception?
A very narrow one. You might be able to avoid discussion only if you genuinely believe having the conversation would cause the patient actual harm, not just distress. That's a high bar to meet.
Right. Now, palliative care. Sometimes giving enough pain relief, like opioids, carries a risk of shortening life by suppressing breathing. This is the doctrine of double effect.
Yes, a very sensitive area. The principle is that giving potentially life-shortening medication is lawful only if the doctor's primary and sole intention is to relieve suffering. The potential shortening of life must be an unintended, though perhaps foreseen, side effect.
So intent is everything again.
Absolutely. And it needs to be documented clearly the intention is purely palliative. Because intentionally ending a patient's life, euthanasia, is illegal.
But where's the line if a dose is almost certain to be fatal?
That's where it gets legally perilous. Some recent case law suggests if the dose is so high that death is virtually certain, a court might infer an intention to kill, regardless of what's written in the notes.
So, extreme caution needed.
Definitely. In those very finely balanced end-of-life situations where effective palliation might predictably hasten death, wide consultation with colleagues, palliative care specialists, maybe even legal advice is essential before proceeding.
Okay, let's switch focus now to confidentiality. It's fundamental to trust, isn't it? Breaching it is a serious professional matter.
Foundational. Patients need to trust that what they tell their doctor stays private. Generally, you can't share clinical details with anyone, relatives, police, employers, without the patient's explicit consent.
But it's not an absolute right, is it? There are exceptions.
It's not absolute. The main exception is when there's a risk of serious harm to others, or sometimes to the patient themselves, or where the law mandates disclosure. It becomes a balancing act.
The ABC v. St. George's case is a fascinating example of this balancing act, particularly with genetic information.
It is. You had a father diagnosed with Huntington's disease, a serious inherited condition. He refused permission for the doctors to tell his pregnant daughter,
who had a 50% chance of inheriting it herself and whose baby also had that risk.
Exactly. The doctors respected the father's confidentiality. The daughter later sued, arguing they had a duty to warn her of her risk, especially she was pregnant.
And the court agreed.
The court agreed that the clinicians had a legal duty to balance the daughter's interest in knowing her risk against the father's interest in confidentiality. They didn't say the doctors had to disclose, but they had to consciously weigh up those competing interests.
And the failure was in not doing that balancing exercise.
Precisely. They failed because they hadn't documented that they'd considered the daughter's need to know alongside the father's wish for privacy. The process was flawed.
So sometimes confidentiality has to be weighed against other duties, and sometimes disclosure is just mandatory by law.
Yes, court orders obviously override confidentiality. Public health laws require reporting certain infectious diseases. The police can require identification of drivers in traffic offenses. There are duties related to suspected terrorism. And in some places, reporting knife or gunshot wounds is required.
What about more general police requests? Say they're investigating a crime and think a patient you treated might be involved. Do you have to hand over information?
No, there's no general obligation to just give patient data to the police on request. The guidance suggests disclosure without consent should only be considered if, one, the crime's great, we're talking murder, rape, serious assault, terrorism, not minor theft or fraud.
Okay.
And two, disclosure must be necessary and proportionate to prevent or detect that specific grave crime. It's a high threshold.
The Dr. Egdell case seems relevant here, breaching confidentiality because of risk.
Yes, Dr. Egdell was a psychiatrist whose patient, W, had killed 5 people. Dr. Egdell concluded W remained highly dangerous. W objected to Dr. Egdell sending a report about this risk to the authorities managing his detention.
And the court supported the disclosure.
Yes. The Court of Appeal said that given the very real and serious risk of harm W posed to the public interest in disclosure outweighed W's right to confidentiality, even though W had capacity and objected. It justifies breaching confidentiality where there's a substantial risk of serious harm.
Okay, finally, let's touch on professional standards more broadly. Research first, there's a built-in tension, isn't there? Surgeons need to innovate, but that means exposing patients to unknowns.
It's a constant ethical tension. Improving surgery inherently involves trying new things, which carries risks. That's why formal surgical research needs strict external regulation.
Through research ethics committees.
Exactly. They ensure the research is justified, the risks are minimized and reasonable compared to potential benefits, that patients give truly informed consent, specifically for the research, and that things like insurance are in place.
But how does a surgeon know if what they're doing is just a small tweak to their usual practice, or if it counts as major innovation or research needing external approval?
That's a judgment call, but an important one. Is it a minor adjustment within established techniques they're already expert in? Or is it a significant departure, a truly novel procedure? If it's the latter, it likely needs more formal scrutiny, perhaps assessment by bodies like NICE in the UK to see if it's safe and effective enough for wider use, or full ethics committee approval if it constitutes research.
And beyond research, there's the fundamental standard of only doing what you're trained and competent to do.
Absolutely essential. Surgeons must only offer treatments for which they are properly trained and maintain their skills through ongoing education and audit of their results.
Yeah.
Practicing beyond your competence is unethical and dangerous.
And this extends to monitoring colleagues, too.
Yes. This is perhaps one of the hardest professional duties, but it's vital. Surgeons have a responsibility to the public and the profession to monitor the performance of their colleagues.
That sounds difficult.
It can be incredibly difficult.
Yeah.
But if you become aware that a colleague's practice is unsafe or falling seriously below acceptable standards, you have a professional and moral duty to act on that information, usually by raising concerns through appropriate internal channels or with regulatory bodies.
Because staying silent makes you partly responsible.
The sources argue yes. Choosing to close ranks and ignore unacceptable performance effectively makes you complicit in any harm that subsequently occurs. It's a failure of professional integrity.
That duty really ties everything together. Accountability, honesty, protecting patients. #tag outro.
So wrapping this all up, what we see is that the modern surgeon carries this complex bundle of duties. Yes, protect life and health, but also rigorously respect autonomy, maintain confidentiality, uphold the highest professional standards, acting with fairness and justice.
It's a lot to juggle.
It is. And these duties, fleshed out in law and ethical guidance, like from the GMC in the UK, really define what responsible surgical practice looks like today.
It seems ethical surgery isn't just about technical skill in the operating theater. It's about, well, being a good citizen almost. Protecting the vulnerable, respecting dignity.
I think that's a good way to put it. It demands integrity and careful judgment at every step, from the initial consultation right through to managing complications and making those incredibly difficult end-of-life decisions.
Which brings us to a final thought for you, our listeners, to chew on. We talked about that Mr. Y ruling, the one that handed back responsibility for life-sustaining treatment decisions from the courts to
A
clinicians.
really significant shift.
So the question is, what does this greater autonomy for clinicians actually mean on the ground inside busy surgical units? How does it impact things like moral distress or burnout when teams are making these life-ending decisions more routinely without automatic court oversight? And perhaps more fundamentally, how deeply must today's surgeon truly internalize and live by the complex principles of the Mental Capacity Act to navigate this responsibility ethically and legally?
A critical question about leadership and ethical resilience in modern surgery.
Indeed. We hope this deep dive has given you a solid framework for understanding this vital area. Thanks for joining us.